the agenda for today. We're going to kick off with Louise in a second. He's going to just give a bit of a background and purpose to the meeting from a Yorkshire and Humber perspective. Then we've got Richard and Mark who have joined us from the national team, who are going to go through a slide set, and then a quick bit of what support we can offer from the Yorkshire and Humber clinical networks and the academic health science network, and then if we've still got time, we'll do some discussion and Q&As. I'm going to now hand over to Louise, who's going to just give you a bit of background and purpose to the meeting from the Yorkshire and Humber perspective. Over to you, Louise.
So, firstly, thank you for coming, everybody, and thank you for your absolute interest in this project. We had 3 CCGs out of the whole of the CCGs in Yorkshire and Humber that didn't come back about wanting to be engaged in this. So at the time of COVID, vaccine delivery, everything else that's going on, you know, actually your commitment to these sorts of projects, you know, is not going unnoticed. So, you know, thank you very much for that. So, you know, for us, what we wanted to do was give you, we want to help facilitate and support you on some of these projects and help develop the implementation and, you know, make doing the BP at home as easy as it can be for you, given everything else that is going on. So what we have done is we've collaborated with the AHSN, and specifically it's Pete and Jenny who are on the call, but actually Jenny is going on mat leave, so it will be Steph that probably you will hear about going forward, because the AHSN have been doing lots of work, lots of projects in each of your ICS areas, you know, around hypertension, around prevention, around BP, you know, discussions around digital. So for us, what we wanted to do in Yorkshire and Humber was, although it's a national project, is make sure it was absolutely firmly embedded and gave it a home in all the work that you've already been doing, so that we're not duplicating, we're not you know, asking you to do something you already do, and we can enhance the offer of things that you are already planning to do or support you in making sure that this can actually become a bit more mainstreamed going forward. We know the SOP is really about those patients that are, I want to say secluded, but they're not. They're shielding is the word. You know, but actually, this is, you know, for me, what this is about digital. You know, in primary care going forward, how we can look to trial with this some of those at-home solutions around BP and hypertension, and actually it's about where this could go in the longer term and in the mainstream. So again, for us, I think somebody needs to go on mute so I can hear a background of a office. If everybody can go on mute, thank you. So yeah, so you know, it's about the future of the digital agenda, of the prevention agenda, and we'll be looking to tie this in and support you going forward. So for me, this is the first step of many, first conversation of many, and we will be around, you know, with the clinical networks and the AHSN working with you, you know, going forward on all of those agendas. So I'm going to leave it there because I know we've got a very packed agenda and a small amount of time, and I think we need to get to the national team to give us a bit of an oversight about the project and to your comments and questions. We'll try and answer whatever questions you have in the chat or bring them in, and you know, anything that we haven't got, we will commit to answering later. So I'll leave it there unless anybody's got any questions for me.
Thank you, Louise. Okay, over to you, Richard and Mark then, if you're happy. I've got your slides all set up, Mark, so if you just want to, you know, let me know when you want to move on and I'll move on for you.
I'd say a few words of introduction, Mark. Thanks, Colin and Louise. I know you're doing the main presentation, Mark, with the slides, but if I can just pick up on some of the points that you already made, Colin and Louise. So it's great to see so many people on this call. Thank you very much for giving up the time, and we're all under a lot of pressure for obvious reasons. And I just want to echo really what you said, Louise, that this whole NHS at Home programme is about, yes, helping people who are otherwise not getting the sorts of services that they would normally get because they can't go into hospital, or they're shielding, or they can't go and see their GPs, and also to reduce pressure on those services. But we do see it as part of a longer term transformation to bring in, yes, appropriate technologies where people are comfortable to use them or can be supported to use them, and to improve in general the supported self-management of people's long-term conditions. And this is the first big project that we're rolling out around hypertension and blood pressure monitoring at home, but we are planning other big national projects to scale this up over next financial year. And then, as you said, Louise, it's very much about making that business as usual and part of the mainstream delivery. But over to Mark now to say more specifics about the BP monitoring project.
Yeah, if we can move on a slide. So I'll let you off for spelling my surname wrong, but my name's Mark Marshall. So I'm a senior delivery manager at NHSX, but I've previously worked for the ambulance service. I've worked in community and primary care. I've worked for the National Blood Service, and I've worked all over the NHS, mainly in operational roles. Oh, I've worked in an acute trust as well. Forgot about that one. All in the Yorkshire and Humber region. So I can see it from your point of view, and I understand your day-to-day pressures. Next slide, please. So there's been three phases to this project. So the first, well, I'll go through the aim first. So the aim is to really, like it says there, to rapidly increase that availability of remote blood pressure monitoring for really vulnerable patients. And these are people with uncontrolled hypertension, and I think there's about 3 million of them in the UK, and they're at much increased risk, an increased risk of heart attack and strokes. And obviously that's bad for the patient, but it's also really bad for the system, because you've got an ambulance taking them to A&E, you've got then an A&E attendance, then you've got the admission, then you've got your rehab, and you've got everything else, which is a massive cost to the system. So we wanted to prevent that, or reduce the risk of that, by trying to control these people's hypertension, by providing lots and lots of blood pressure monitors for these patients. So phase 1, 500 devices I think were given out to early adopters, and that was in, I think, about December. Then phase 2, which is happening now, this has been the distribution of the 22,000 devices, and that's what we're in the middle of now. And then there'll be a further phase where we're procuring lots and lots of more devices, another about 150k devices. Sorry, I'm just looking in the chat and someone's put, I may have a problem.
Sorry, my slides haven't changed. I might have to log out and log back in again. Sorry.
My other option, I can send you the slide deck if you want, Rob, so you can.
That's some trouble. Thanks, Louise. Yeah,
I'll do that.
Cheers.
That'd be helpful.
Okay. Next slide, please. So this slide just basically explains who was targeted, which cohorts of patients, and like it says there, it's basically, you know, the vulnerable patients, elderly, people with uncontrolled high blood pressure, and that did include some care home residents. Another thing to note, I guess, is a lot of people already have blood pressure monitors, already. They've already bought them because you can get them from Boots or wherever. They're relatively cheap. So so they can be included in this piece of work. There's no, and I think they are mentioned in the draft clinical pathway. Next slide, please. And another reason we're doing this is because there's a lot of national evidence of the benefits of trying to control people's hypertension, or specifically getting patients to do it at home. So there's evidence that they basically get better outcomes if they manage it themselves, because they'll take that ownership and that behaviour change, and it is cost effective, and it reduces the amount of GP consultations and time it takes to have those consultations. Next slide, please. So the programme that we're working on nationally is there's 5 basic work streams. One is the procurement one, which is about procuring the next lot of devices. We're obviously we've got an evaluation work stream where we're looking at what data we need people to capture, how we capture that, what data sources there are, how can we make that as automated as possible. And I think our conclusions are really that we want to make it really as simple as possible and not too onerous on local systems, given the pressure where everybody is. So I think our immediate thinking, although this hasn't been approved yet, is that there'll basically be a quick questionnaire that comes out and needs to be filled in on a regular basis for the 22,000 devices, and it really is things like, have you sent these to GP practices yet? Are they with patients yet? And that's more or less it. And going forward, we want to use SNOMED codes and try and really pull data from systems that are already exist, like I said, to try and make that as easy as possible. And we're really planning that for the bigger procurement. And then obviously we've got a mobilisation work stream where we are looking at how do we support local systems and local regions, what resources do they need, and what assurances do we need from a national point of view to make sure that we're assured that they're not just sitting on a shelf somewhere and are actually being used as we intended. And then there's the distribution work stream, which was really around making sure that they're distributed to the CCGs and how all that works. And then we're planning for the next phase of the distribution when we procure the next lot. And then we've got the final bit, which is really the NHSX led part, which is the digital pathway. So what we mean by that is that across the country, there's a number of digital platforms that exist that you could use to measure blood pressure monitors. That patients could input and measure their own blood pressure, and then that would be collated and go into the GP record. So we're just mapping that out and seeing what we need to do to make that work. And if you just do the next slide, please. And this is what that looks like. This is all the remote monitoring schemes that NHSX has funded. There might be some more out there, but as you can see, there's a number across all regions, and it's just, and what all we need to do is talk to the suppliers and the people who are using this, and just understand its functionality, which ones that can be used for blood pressure monitoring, and what training needs do we need to do for that, and how do we get it working, and how many licenses we got. So we're just kind of collating all that information, and the other thing is that these can be used as a data source as well. So that's our plan, but that's a little bit more medium term. And if you do the next slide, please, Colin. So what we're working on right now is I've set up a DPS for procurement. We're looking at the logic modelling and data capture and what that looks like. Support for local implementation, and obviously we've got lots and lots of meetings going on, and we're also doing some planning for the next financial year in terms of, can we get more money for this? What's that look like? And over the next coming weeks, I'll be doing the procurement, probably start that next week or the week after. More automation of the data, so that's the SNOMED codes, etc. And then more detailed information for people like yourselves about the digital platforms. And another thing that we're working on as well is setting up a space on NHS Futures where we can put all relevant information from early adopters, from other regions, from people who are doing things, and their templates, their forms, their SOPs, whatever else would be useful. And then in the coming months, we'll be distributing the next lot of devices, and that will most likely follow the same route that the 22,000 took with the expressions of interest. And then it's more of the same then, and then so more info about the digital pathway evaluation. So we'll be starting that evaluation work and what that looks like. And we're trying to get more money to support this, so that's something that we'll know whether we've got that in the coming months. And one of our really ultimate aims is to get blood pressure monitors on prescription. So our chief exec is lobbying the powers that be really to try and make that happen. And then next slide. Oh, that might be all my slides. No, that's it. Any questions? I suppose before we do any questions, I don't know if Richard wants to add anything or feels I've missed anything.
Not really, Mark. That was excellent. Thank you. Open to questions and feedback when.
Okay, thank you, Mark, and apologies for I put you down as Mark Matthews on the agenda. Apologies.
All right, I'll let you off.
Sorry. Thanks both to you and Richard for that excellent presentation. We've got some questions in the chat box. Louise, were you going to?
Yeah, if I got some of the questions in the chat box, I'd got a couple of questions for Mark and Richard. Yeah. One of the things was there's been, so thanks for going through the phases and the timescales. That's been really, really helpful, actually. But I know that it's been muted about accelerator sites. And that people could be interested in being an accelerator site. I wonder if you could describe a bit more about what that looks like as opposed to just being in phase 2.
Good question. What my understanding of it is that it's kind of more intensive support, but what you have to give back from that is more detailed information so that we can share that learning with everybody else. So that's basically what it will mean. But I don't think they've not all been identified yet. But that's what it is. I don't know if that's helpful, but that's my basic understanding.
Yeah, no, that's helpful. It's because we've been asked to see if anybody would be interested, and obviously it's really hard to say what the give and get is to get people to be interested. No, that's fine. My other question was around the standard operator, the clinical pathway that you'd mentioned. Yeah. I know we've got a draft one, and that's gone out, and we've shared that widely. Do we know what kind of point that is in the development? Is that going to be signed off soon? Is there still chances for our clinical leads to give comments on that?
I mean, yeah. I mean, if it's in draft, so if anyone's got a really specific comment, yes. But the stage it's at, I believe, is like the final sign-off stage where it gets kind of proofread, and it's been through the clinical groups to say, yeah, they're happy with it. But one thing I would say, there's no reason why you can't take that and you know, make your own local one if that works better.
Thanks, Mark. I think some of us have been through pulse oximetry at home and been a bit burnt by national SOPs versus local. So it was just trying to understand where that was. So thank you for those two. There is a question from Vicky in the chat that I answered. You did mention that patients can use their own BP machines, because obviously, as you say, people may already have those or wish to buy them. Do they have to be from a recommended list if we're thinking about linking into digital solutions?
They do. They have to be on the British Hypertension Society. They've like got a really big list that they've validated, and all the big suppliers, they go through a process to make sure that they're on there. British and Irish Hypertension Society.
Great, thank you. And there's definitely a lot of positive support about the data capture coming directly from, you know, the SNOMED codes and an automated approach. Again, we've had to do something similar with the pulse oximetry, so there's been lots of lessons learned that we can share if they're not being shared across nationally currently. We had a question about Tracy keeping the device, and Richard, thank you. You answered that it's as long as they've got as long as they need it, that it will stay with that patient. Pete it has put in a really good thing about the digital platform solutions, and we would be willing. Certainly the HSN has done already a lot of work around that, Mark, in Yorkshire and the Humber, and also would be helpful facilitating any of those conversations locally. Advice on patient. Oh yeah, is there anything around patient prioritisation? So thinking about the mass rollout, you know, there's a lot of patients on hypertensive lists, or those that may be undiagnosed hypertensive. So is there going to be a plan to kind of prioritise who we give these patients, who we give the machines to first?
Not undiagnosed. I suppose the view is from the national team is that there's just so many of these patients that we're not. This is not about looking for more, although, you know, that probably needs to happen. And I know some other areas are kind of trying to develop algorithms which basically search their GP database, their patient list, and tries to pick these people out. But no, that's not in scope of this project. We are looking at the ones who are already diagnosed with hypertension but are not really being managed.
Yeah, just as I think absolutely the undiagnosed, but actually as part of that diagnosis, to understand whether they are hypertensive, seeing, you know, using these machines at home over a period of time has got a really good, and then keeping them as part of their management is probably a good thing to look at. I think it was more about prioritising. There is so many patients. Is there prioritisation planned of who on our massive hypertensive list we should give these BP monitors to?
It says in the SOP it's patients who are clinically extremely vulnerable, and it's got the definition of what we mean by blood pressure, high blood pressure for these purposes. And also, you know, there is an issue in terms of focusing on people suffering from social deprivation who can't afford to purchase their own monitors.
Great, thank you, Richard. Mark, I think you just mentioned about some areas are doing searches on their GP systems. Pete asked a question: is are there a set of off-the-shelf searches? And I suppose if areas are doing those, could we not just share those nationally and save the pain of others, you know, developing that?
Yeah, I can take that back. I think it was people who developed their own kind of bespoke systems, you know. But I can take that back as an ask.
I think there's definitely a lot of in the chat when you look, there's quite a few people saying definitely key for advice on searching and then prioritisation, etc.
Yeah, we're definitely looking into that. I think I'm hopeful that we will be able to make some search tools available. But it's a matter of what extent they're going to need to be tweaked, and also I don't know whether there might be different local criteria that you would need to use depending on particular practices.
Brilliant, thank you. And
got his hand up, Louise.
You what? Sorry.
Pete's got his hand up.
Pete, do you want to come in and then I'll go back to the chat questions?
Yeah, thank you. I just thought it was easier while we're talking about searches rather than chat. So yeah, we developed some searches in West Yorkshire and Harrogate for a particular project. Not necessarily suitable for this, but actually it is really important to try and get those centrally created searches for consistency, for ease of others, and even little bits of learning we could share with you. So for example, when we created searches, if you went for greater than 150, it threw up a lot more patients than if you went for greater than 151. There was like some coding issues, and it's all them little intricacies that people on the ground kind of know about that might make the difference between creating a list that just looks absolutely mind-blowing versus a couple of little things that you can do on the ground. I'm not an expert, but certainly we could share some learning with you.
Yeah. Thanks, Pete.
So a couple of more questions in the chat. I mean, a lot of our practices are using Arden's templates now, and if that can be linked to the SNOMED codes, I don't know. It's looking as though people have already spoken to Arden's about this and they're not aware of that. Rob Thompson, do you want to come in on this point?
Yeah, happy to. Like you said, Louise, we got our fingers bent so badly by the oximetry at home thing. I decided to tip Arden's off as soon as possible about this. So I sent them the SOP through and asked if they were aware of it and if there was anything that they were working on, and they said at the moment they weren't. So I can only agree with everybody that's saying that we need this to be, centralised and, if possible, using Arden's. That would be really helpful.
Mm-hmm.
So
I think they've got a lot of the market at the moment, haven't they? So most practices are using them, certainly in Hull and East Yorkshire.
Yeah, and I think certainly across West Yorkshire, I think as well, it's been really helpful when we haven't had the SNOMED codes yet as an interim to make sure that people are recording things systematically. I think somebody needs to go on mute. I'm just got an echo. So Peter has put about, could this be targeted initially at a subset of practices or PCNs in the CCG rather than it having to be a universal offer?
That's actually something that we would encourage, because actually once you get down to GP practice level, even PCN level, the number of monitors isn't very great. So some may not consider it worthwhile, but if you, for the sake of argument, only issued them to half of your PCNs, then it's a more worthwhile effort, isn't it, in terms of investing the work to get them out there. So, but that's up to local decision.
Great, thank you. So, our people that are really wanting to go on this, we should just champion and use them first, by the sounds of it. Now, Tracy's got a really interesting question. What happens about the calibration of monitors if they belong to the CCG but are actually with patients? Because obviously we know for our other medical devices and equipment, calibration has to happen on a fairly regular basis to make sure the accuracy of the equipment.
No, these don't. They're viable for 5 years, basically. So
we would need to just kind of put a prompt that in 5 years a patient would need a new piece of kit. Is that kind of how it would work? Great, thank you. So I know there's somebody wanting the pathway, and we can share that around. Now, there's something here about it's saying either 150k coming down the line for YH or national. I don't know anything about 150k, Bruce, but I mean, we can certainly ask about money.
I think it's
It wasn't the money; it was
I think that's the
the
number of
devices.
monitors, isn't it?
It's that's
Sorry,
that's
Bruce, that's me, but definitely I'll ask about money as well.
yeah, no, that's a national. It's a figure that's for everybody. So you'll be apportioned, whatever you get apportioned. I don't know. Richard did the portioning out.
Yeah, we did have an issue with the portion actually, in that there was a cap on larger CCGs. So some of our CCGs, when we worked out the numbers by deprivation, they would have over kind of 200 devices, and the cap was on 150. So some of our CCGs, proportionality, I won't get as many as some of our other CCGs. So I think that was potentially an issue for us in Yorkshire and Humber.
If you could drop me an email with the details of that, Louise, I can get the team to look into it. Initially, we just wanted to get as many out to as many CCGs as possible. And of course, I don't know if this is relevant in your region, but some CCGs are merging, which it causes a slight complication. And initially we did our own allocations based on index of multiple deprivation down to CCG level, and we're limiting the initial distribution to that per CCG. But we have got some stock left, which we will be distributing now to CCGs that didn't obtain the number that they requested, as long as it's within the total allocation for the region. But my understanding is that is mainly regions in the south and the Midlands.
Yeah, we did ask for our maximum per region, to be honest. Yeah.
Right. Yeah.
Well, no, actually, we'll have 3 CCGs that haven't, because they didn't engage. So maybe we can look at that. We'll sort that out, Richard. Thank you. Yeah. So if you're just thinking though, if you're a accelerator site, is there an option for more BP monitors to make it more widespread? And is there and in terms of money and support, is that something that an accelerator site would get?
The short answer on the monitors is at the moment there aren't any additional ones beyond the existing sort of allocations within the region. So that would only be up to a region if there are any remaining for you as a region, or even reallocating within the region if one CCG finds that they're not in a position to really pick up on this and get them out to patients. That's our top priority, to get them out and in use with as many patients as possible, of course. And certainly, we are keen to encourage those CCGs that are getting them out to patients. And if it was in our power to make sure that they had more devices, then we would probably do that nationally. It might be something that we'd consider for the next batch. We're not now expecting them to arrive centrally until late March.
Great, thank you. And Tracy's put a question in saying, given COVID pressures, is there some flexibility about extending the distribution of devices in general practice to patients from the 3 months in the SOP? So if you can get some out, but you can't get all out because of the vaccine bit, is that an absolute given, the 3 months, or can we have some flexibility as long as that they are starting to get out there?
Well, ideally, I think this comes down to yourself as systems where you really, ideally, you would target and you would put these where they can be distributed and used as soon as possible. We're sympathetic of the pressures that we're under, so you need to go as quickly as you can. And I've got to leave. I'll just nip off because I've got to present at somewhere else. But then I'll come back as soon as I've done that. So I'll leave you in Richard's hands for now.
I think the lesser the data burden and asks of the CCG and the general practice, the probably easier it will be to roll this out quicker given COVID pressure. So I think
Yeah,
That would be the
no, absolutely. Every area's been telling us the exact same thing, and I don't know if any were on the call yesterday, but I think David was. But anyway, yeah. So yeah, we've got that message, and I will be taking that back. So I'll see you shortly.
Great, thank you.
Cartha,
you've got your hand up.
Hi, morning. Yeah, I was just really just to tell you, Sarah Pollard very kindly put in the current sort of BP SNOMED codes, which can be used for recording things like average blood pressure. So the existing codes, which is great. I just wondered if you could just give us a sense of presumably the SNOMED codes you're looking at now are to say that somebody's registered on this system, and therefore just to sort of flag up what's happening. But is that also for your evaluation of the scheme? Is that why the SNOMED codes are so key?
That's what we initially emphasised, because these ought to be recorded routinely anyway. If there one or two other sites have raised questions about the exact SNOMED codes, I'd have to take that away. But yes, the purpose of requesting you make sure that they are recorded is for evaluation purposes, so that we can collect that data. And of course, we appreciate that some of those readings may be from people who purchased their own monitors. So we'll have to think about how we take that into account in terms of this particular project. But if a byproduct of our project is that more people with their own monitors are using them more effectively, and that's being recorded, then that's a bonus.
Thank you.
Thanks. Robert, Rob, you've put something in the chat. Do you want to just say it? Would that be helpful, seeing as we know hands up?
Yeah, it's just it's always been very helpful for GP practices when changes to the QOF and enhanced services come out, to actually have that agreed set of business rules in terms of coding, because I know from experience people can go off in all kinds of directions when it comes to clinical coding, so actually having something that's really explicit would be good. Sorry, I sound like a bit of a stuck record on this, but it really is important for practices.
Thank you.
Great, thank you. Has anybody else got any other questions? Because I think we've answered everything in the chat. Richard, is there anything you'd like to add at this point?
No, I think we've got another presentation, haven't we? Yeah, there's another brief one. Can I just ask a quick question, Louise, to Richard? I don't know if you'll know the answer. Might be better placed, but I'm still not clear if we get some of the monitors out right now, how the people using the monitors are going to be recording their stats and sending them back into the practice. I think that's something that possibly on people's minds, because is there currently an electronic solution for that, or? That's a good question. I thought you would be asking that. So the basic monitors, of course, are not Bluetooth enabled. So people, whatever monitor they're using, they will have to somehow make a note of the readings, and then either phone them into the practice, email them into the practice, or if you are implementing, some practices may be implementing digital platforms, and that's what we're hoping to support you with, because clearly in the medium term it's a priority to get as many practices and patients using a shared regional digital platform for this purpose, so that reduces the the manual overhead, and it's easier to gather data from that. But that's clearly not something that can be implemented overnight. But each region has got its own recommended platforms, and that's what NHSX and Mark are working on. Is that helpful? So, but in the interim, it's down to individual PCNs practices what process they use. Okay. Yes, that's helpful. Thank you. And Natalie, you did have your hand up, but you put it back down again. I'm not sure.
I've just taken it down because I noticed Suzanne Cabby from the central team had sent us like a test link, and it was basically to basically ask CCGs to try and submit data in regards to distributing monitors from the CCG to primary care services. But I think she was just testing the link to see whether it works. So we might use that in the near future. But I think we'll be in touch once Suzanne's confirmed whether it's to go out or not.
Yeah, and I think on the back of that, Natalie,
link.
On the back of that, Natalie, for us, again, learning from the pulse oximetry, one of the real burdens for CCGs has been the questions about how many pulse oximeters have you got out there? How many have you got left in your storage? How many have you got left in total on an ongoing basis? Some of this is, let the CCGs manage their own stock, let them be able to, request any more as and when they need. And obviously we can give high level numbers of people that are on the scheme. But again, that burden of reporting on things that actually we maybe don't need to be, I think is one of a message that we would kind of like to go back, Richard, on behalf of our CCGs.
I hear that. It's always a difficult balance, isn't it? Because our directors want to have the evidence that this project is being effective and that it's being effectively used. I know Simon Stevens, is very concerned that these devices end up sitting in a practice cupboard or under a bed, as some initially were. And particularly at the moment where we're looking to achieve further funding for next financial year.
Yes, I think it's about streamlining and having the bare minimum as opposed to counting for counting's sake. I think is what we would come from. We would agree we need to evidence, that we're using them. So I doesn't look like we've got any more questions at this point. So I'll move us on.
Yeah. Okay. Okay, thanks to Mark and Richard for that, and I hope I'm right in saying, Richard, that on behalf of you and Mark, that you'll be around to be a link for us to the national team, so that we can field questions to you and get some support from you nationally.
Sure, that'll be more Mark than myself. Yeah.
Yeah, brilliant. Thank you. Okay, so the next bit is just a quick slide around the support that we can offer to the CCGs in the Yorkshire and Humber region, and that's both from the Yorkshire and Humber Clinical Network, which myself and Louise are part of, and Claire, and the Academic Health Science Network, which Pete and Jenny and soon to be Steph are from, and the sorts of things that we will do and can do for you as you get involved in this programme. We can do things like this meeting, facilitate meetings like this and workshops. We've already talked about the possibility, and we'll take a steer from you around 1 or 2 meetings in individual ICSs. As you know, we've got 3 across the Yorkshire and Humber region. So, and we've done similar in the pulse oximetry and the long COVID work streams. We'll be a conduit for questions and links to the national team, and you've already got some evidence of that today with Richard and Mark, and we can keep in close contact with them. Some link to clinical advice. Obviously, we're a clinical network. We have clinical advice, and so do the Academic Health Science Network. And there are lots of clinicians who are on this call today and are involved already, so we can bring that in. Peer-to-peer support is always helpful, and meetings like this and bringing you all together and sharing learning and best practice is something that is usually something that everybody finds helpful, so we can do that. Collating relevant information and sharing, and things like facilitating a space on Microsoft Teams, which I have already set up a space on Microsoft Teams, which I will send a link out after this meeting, and also there's it's already been mentioned today, the Futures platform. There is an at-home section on the Futures platform. There's already a place there for the BPM at home. It's just got the standard operating procedure sat there at the moment, but I'm sure that the national team are going to be sharing lots of stuff there, and we'll send a link out to that as well. But we can try different ways of sharing. The Futures collaboration platform is quite big, and it can be difficult to navigate sometimes. And then we can do a lot of sharing on Teams, but also I've put together a bit of an interactive PDF which I'll send around after this meeting as well, which is just an attempt to bring all the relevant information together in one place. And yeah, we'll send that round. I've already started to put together a frequently asked questions document, which, because we've already had a lot of questions emailed into us, and the national team have answered some of those, and I've put that into a frequently asked questions. But the national team are also developing an FAQs as well, so we'll share that as well, and I'm sure that they'll probably put that up on the Futures website. So that's it really. That's what we'll do for you, and we'll support you, in as much as we can, and any way we can.
Richard, is there anything else additional to obviously what Colin's gone through there that you think you would benefit from us doing or supporting with, or are you kind of happy with the wraparound type support that we're looking to do? You can put things in the chat if you think there's anything additional that you might benefit from, or just give us a nod if you think we're doing the right things and supporting you in the right way. It's always useful for feedback for us. Yeah.
Okay, so I think that's it for my slide, Louise. I think we were going to go on to a bit of a discussion and Q&A.
Yeah, Richard had his hand up.
Well, as there was no questions coming from the audience, I was just wondering if it's worth a brief discussion on this topic. My understanding is that the real overhead for an individual practice is, first of all, running the search, but then that identifies in a number of patients. Then the overhead is actually handling the communications with those patients, letting them know that these are available, that they're eligible, arranging, checking their eligibility, and then getting the devices to them. So I'm just wondering how people are handling that, and whether there is anything that we could potentially look to offer nationally, maybe through the HSN, to support that process. So maybe how much of it can be automated in some way, for example.
Rob's got his hand up.
Yeah, that's a very interesting point, because as Louise mentioned, certainly locally we've had quite a bit of pushback from our local medical committee regarding the oximetry at home scheme, about where it fits in terms of, is it an enhanced service, how practice has been expected to provide this service. So if there is something that could be done, it would be about actually having that consultation on a wider footprint about where this sits in terms of how practices are expected to deliver it. Is it part of the extra money that's been given to support them during COVID? Because that's the kind of stuff we get pushed back to us locally from our practices and our committees is, what is this? It's just like come out of the blue, but there's no contract, there's no service level agreement, it's not in the GMS contract, it's just appeared and you're expecting us to deliver it. So having those discussions broader would be quite useful, because it would answer those questions for us about where this comes from and how practice is, and the contractual mechanism for which it's supposed to be delivered by.
I have to say I was thinking more in terms of practical support rather than changing contracts or funding. I mean, I think our view would be that that there's a duty on practices to support all their patients with hypertension. It's difficult for them to do so the way they would have done normally. So this is an alternative offer that will support the work that they should be doing in any case, and to support particularly the patients who might be suffering from social isolation and social deprivation, rather, to enable them to get a service without having to come into the practice.
And I have to say, I don't think you'll find anybody disagrees with you on that, but I think the reality of people like myself who've had to deal with general practice for many, many years, these are the kind of questions that we get, and it's the kind of pushback that we get from our practices. And I think it'll happen again.
Sure.
Yeah, I think the pushback bit, Richard, you know, the care and the giving out of the BPs and the clinical advice isn't the bit that they question. The bit is about, you know, the searches, any of the data burden, the reporting, the certain things like that, that actually, you know, we're having to take time out to, educate the staff around this and the patients and the comms. That actually does have a capacity issue for practices, and that's then where it comes of, well, where does that sit? Where is it within our, you know, our arrangements? Do we have to do it? You know, pulse oximetry at home started off as being recommended, then became mandatory, was given very tight timescales. It's things like that that actually means that, you know, while it's flexible and an optional thing, and people that are seeing it as a benefit can join, that's great. It's when it starts becoming a more mandatory, rolled out bit that the laggards and the other bits, that it makes it quite hard for our job to make sure that we have got absolute engagement across all our practices and delivery across all our practices.
Yes, understood, and that is why we actually, as I said earlier, encourage you to support those practices that are keen to pick this up initially.
Yeah, good point. We've got a hand up from Sam, Louise. Sam, do you want to come in?
Yeah, I suppose my comment is, I think there's something about scale, because we've got 170 beep ordered and arrived. We've got 50 practices, so you're therefore talking about essentially 3 or 4 patients per practice. Yeah. So I think rather than it feeling like a big automated process, doing big searches, calling patients in, this feels like a more curated, you know, who are your small number of difficult people you're worried about per practice that you might need to do something for. And I think that sort of focuses the work differently somehow, or it has to be because of the scale, because you can't offer this out to all the people with hypertension by any stretch of the imagination, because there's just too many of them and too few devices for that.
That's really helpful, thank you, Sam. And yeah, and again, then at a CCG level, you can take a decision in terms of which PCNs to favour, perhaps particularly areas where they're suffering social deprivation.
I've just got one last comment, Richard, I suppose, for me is, as a previous practice nurse by background, that I know that the bulk of my patients, or a lot of patients that have got hypertension, you know, need a larger cuff as opposed to a normal size cuff, and the ratio is a lot higher to get an accurate BP. There's lots of work being done around the appropriate size of the cuff for the BP, machine, and there is lots of our patients, and more than you think, need a larger cuff than a smaller cuff. And I know the ratio that's come out from the national team in this phase is a very low ratio of large cuffs to BP machines.
That's really critical information, Louise. And if you can put something in an email to me in the next day or two, because we're literally about to start the next procurement, and we really need to know that. It's very hard for us to get that. You get
false recording. It's absolutely well known and well thing. So yeah, some areas haven't even got any extra large cuffs yet. They've got 100 and odd BP machines. So it's absolutely a critical bit.
We've been trying to find out, who made the decision. I think initially it's only, I think, 2% of devices for which we've got the extra large cuffs, and we frankly don't know whether it needs to be 3% or 5% or 10%. So any data that you've got that you can send me will be really.
And I'll speak to our CVD lead, who's a GP, and he probably will also have a really good kind of percentage ratio, maybe some degree for to give you some figures. Colin, you've got your hand up, and I'm really conscious of time.
Yes, we've got 2 minutes left. It was just for you to take back, Richard. I wanted to give a shout out for the patients. Just if there is anything around support to the patient for helping them to do this, because I think we all think that patients can just take a BPM machine and, you know, off they go with their BPM monitor and do this. And I'm not so sure that that's the case. I think that they need support. So anything that, you know, the central team can do in those terms as well, and us from a Yorkshire Humber perspective as well. But yeah, that was it from me. Louise, we'd better sum up, I think, now, because we've only got a couple of minutes left.
Thank you everybody for coming. I think what's been quite obvious is actually we're at the early stages of this, of the BP at home, and I'd really thank Richard and Mark for coming and hearing, because it feels like we can be a bit more part of the development of this than we were with the pulse oximetry. So you know, I think that's great. This will be the first of you know, many conversations we'll have around this. We will look to you know, put on sort of webinars more for your clinical teams, for maybe your PCNs, and support that way next time. So let us know if there's anything you think that'd be useful for them to know about this, and to have events on. And you know, I think we got support for the in the chat for the structure that we'd put in place around supporting you all with from the clinical networks and the AHSN. So we'll move forward with that. And I think, Richard, maybe that we'll look to try and see what we can see around Accelerator site, and whether we can you know, help you shape some of this more from a national perspective, and be a partner with you, if that would be okay. And thank you for coming, everyone. Anything else, you know, we will share our key kind of things that we discussed. We've got the frequently asked questions, so we'll put all your questions into that. We'll share all the stuff that we've done so far and to date, and we'll just keep on working with you. And thank you, everybody, for your continued engagement at this difficult time. We really, really do appreciate it. So thank you, everyone.
Thank you, everyone.